Très bien. Alors, mesdames, messieurs, bien.
Ladies and gentlemen, welcome to this press conference to go over the situation in Quebec about COVID-19. The Premier of Quebec, Mr. François Legault, is together with the Minister of Health and Social Services, Ms. Danielle McCann, as well as the National Director of Public Health, Dr. Horatio Arruda. Mr. Premier. Hello, everyone. I will start first with the daily numbers. We have 93 new deaths for a total of 1,134 people. So, of course, I wish to offer my condolences because let's never forget that behind these numbers are real people and real families. Over 1,000 families who have lost a family member. It is important and it is very sad for Quebec as a whole. We now have 20,965 cases, an increase of 839. We have 1,278 hospitalizations, an increase of 54. We have 189 people in ICU, a decrease of 2. Of course, the great challenge that we continue to be faced with is to find the means of attracting and bringing in additional staff in our residences for our elderly. I was telling you over the course of the past few days that we needed 2,000 people, and I was telling you yesterday that we had found 1,000. And out of that 1,000, there are 350 specialists, doctors, whom I wish to thank. There were also students, nurses, orderlies who were in the hospitals. We thought yesterday that we'd be able to find the last 1,000. Unfortunately, we weren't able to do so. We spoke with, I think, over 1,500 specialists. But what we're looking for, and I repeat it, are full-time people. And it seems that it is difficult to go over 350 on the specialist side. So we're continuing to train students, but who are not ready as of now. So we still are missing 1,000 people, and that is why I made the decision today. We officially asked the federal government to have 1,000 soldiers from the Canadian Armed Forces who will be coming in our CHSLDs. Of course, these are not people who have medical training, the people who already did. There were 65 of them, perhaps another 65 that will be coming up, but now we're asking for 1,000 people. It's not an ideal situation, but at the same time, I think that it will help us out a lot to be able to have additional hands, to be able to do those tasks that are not as medical, and to help out the staff that is insufficient right now in CHSLDs. In order to take care of our elderly correctly, to take care of the people who need help right now in CHSLDs. Right now in Quebec, it's almost as if there were two worlds. On the one side, we have the very difficult situation happening in the CHSLDs, and on the other hand, we have a situation that is relatively stable, particularly if we look outside of the island of Montreal and the island of Laval. If we look, for example, at the death toll since the beginning, 74% of the deaths have been either on the islands of Montreal or Laval. That is to say that if we look at all the other regions of Quebec, the situation is pretty stable per capita, and things are going, all things considered, pretty well as far as the spread, or rather the non-spread, of COVID-19. And that is why we have continued our discussions with Dr. Arruda and Dr. Massé in order to, next week, to be able to present a gradual reopening plan for the schools. Now, we will be presenting that plan next week, but I already want to reassure parents. We are going to make sure in this plan that those parents who, for all sorts of reasons, do not want to send their children to school, they won't be forced to do so. So I want that to be very clear, and we will be taking the measures so that those children can do the necessary catching up when they go back to school in September. So that's important. I wish to really reassure those parents who prefer not sending their children to school. They will be able to keep them at home. Of course, that will be done by region. So we'll go gradually, starting with those regions where the situation is very stable. We are going to be continuing over the course of the next few days, and that is why we are giving ourselves until next week to be able to present that plan. And Dr. Arruda and myself were following things on a daily basis, and if things remain stable, particularly outside of Montreal and Laval, we will be able to start proceeding to the gradual reopening of schools with a certain level of guidelines. Same thing for businesses. We will be presenting next week a plan to reopen businesses. And as you will be able to see, it will be very gradual. The idea being to go little by little and to make sure as we go along as well that we don't see a new wave, that we don't see the contagion curve start going upward again. So we'll be doing this very prudently. So, of course, announcing a plan ahead of time, it will allow the heads of the different businesses to get ready and to also get ready to set up the guidelines that are going to be proposed by public health. But I just wished to tell you that if the numbers continue maintaining themselves, especially outside of the islands of Montreal and Laval, we should be able to have some good news to announce next week, as much for the schools as for businesses. My daily thanks. I wish to thank all those workers who came back in the construction sector, the residential sector, I mean. I know that a lot of Quebecers were worried that we're supposed to have a new home or a new apartment on the 1st of July, and they were thinking, well, I'm supposed to be moving. Is that going to even be possible? So I wish to thank all those who came back to work in the residential sector, residential construction sector, I'm sorry. So I would like to end by saying that, yes, the situation is difficult in CHSLDs. But if we look outside of CHSLDs, and particularly outside of the Montreal and Laval regions, things are still pretty encouraging. And so I think that we're going forward, and we're on the right path, and we will end up getting through it all together. English?
Good afternoon. The situation in senior residences is still critical. Today, we've asked the federal government to send 1,000 soldiers. It will give us more resources to help us with non-medical tasks. Outside the senior residences, the distancing measures are working. The next few days will show if we're really on the right side of the curve. If it goes well, next week we'll announce our plan to reopen schools. And as I've said many times, public health will be our top priority. I can also already say that the remaining weeks of the school until this summer won't be obligatory. So it means that parents won't be forced to send their children in open schools. We will also next week announce our plan to reopen the economy. Our challenge will be to restart the economy without restarting the pandemic. And businesses with this plan will have time to prepare accordingly. So we must continue our efforts. We'll get through this together. Thank you all.
Merci, Monsieur le Premier ministre. Alors, pour la période des questions...
Thank you, Mr. Premier. We are now going to start with the question period. Taking into account what you've just announced, Mr. Premier, do you have the intention of making the wearing of a mask mandatory? Do you mean in schools and businesses when they reopen? Schools, businesses, the street, to make them mandatory? Listen, that's a good question. And that is one of the things that I wanted to talk to you about. I have three things to talk to you about. First, the death toll. Second, the invisible impact. And the question of the masks. So I'm going to start with my two other subjects, if you'll allow me quickly. So very quickly, I wish to tell you that without wanting to minimize at all the drama of these deaths and the suffering in the families, I want to say that Quebec is probably one of the places in the world that calculates the most scrupulously the deaths linked to COVID-19. Making comparisons between countries who don't count the same way is something that is that can bring us errors. It's comparing apples to oranges or even bananas. Most countries do not take into account deaths that take place outside of hospital settings. If we did that, we would be one of the places where we would have the fewer deaths. We'd have very beautiful results to announce, but they would not be accurate. There are countries that do not take into account that what happens in nursing homes, whether they be private or other, because they don't have the system to do so. And if they do, they can attribute sometimes the disease to another factor and not necessarily to COVID-19. So you understand that we, for example, if we have an epidemiological link, as soon as COVID-19 could be the case, we put it as the cause of death, whereas elsewhere that is something that is not done. I mean, look at situations where there's a lot of heat in the summer, whereas we have very few cases that wait. There are very few places that do the same thing. We declare them right away. And also, other countries only declare the people who were tested. Here, we count the deaths for whom I said there was an epidemiological link, therefore cases that were not taken into account in other places. I also wish to remind you that every year, generally speaking, there's about 1,000 people per month who die in CHSLDs, and we have to also understand that the present deaths that we're taking into account associated to COVID-19 would have taken place despite the situation. And I'm not saying any of this to minimize anything, because there's a lot of debate. You know, there are people who are saying that we're hiding the numbers, that we're misleading. And I want to say that we're very transparent. We could be more scrupulous. We might have decided to not put the epidemiological links, but we decided to do it because we think that this reflects the reality. And I would like to say one thing. When all the states end up counting the deaths above the observable tolls from previous years, that's when we'll see the real numbers. So I wish to tell you that we'll see with time, and then we'll be able to make better analyses to understand what happened in Quebec. Another element that I find very important to say, because I think that we have to give that information to the population. We made a very early and very important stop. Experts, independently from me, says that we saved between 30 and 60,000 lives in Quebec because of the impact that we had on community transmission. So we had a healthcare system that did not end up being overwhelmed. And that decision had an important impact, which is invisible, which I call the invisible impact, and that we all tend to forget. And that is why we want to reopen very progressively to avoid that this invisible impact become visible again and that we overburden our healthcare system. Now, to answer your question on masks and that I would call the face coverings, yes, we're going to make the recommendation to wear it, but to wear it especially when you're not in a situation of being able to respect the 2 meters. Now, as far as the obligation and penalties, does it have to be done in public transportation? This is something that we're having a look at. I can tell you that it's going to be announced very, very shortly. And, of course, before the deconfinement period. But you'll understand we'll take every single measure that we can to protect people. And I'm going to repeat it again. That measure of wearing masks or any face covering will only be efficient if people wear it adequately, that they don't contaminate themselves, and that they do not forget, especially to wash their hands. I know that I'm driveling, that I'm repeating, that I'm reiterating, but it has to be done, and we will have teachings to help Quebecers. But let's not, get 1 meter away from people because we're wearing masks and we think that they protect us as if we were superheroes. Thank you. I have a note in my hands that I would like to briefly read you that was sent to all doctors of the Laval CIUS by the Officer of Prevention and Control of Infections in Microbiology. What is written, amongst others, for doctors that there is no indication of that wearing a mask N95 in CHSLD right now, that there is no in CHSLD with residents who are suspect or confirmed of having COVID-19. It's also written that requiring wearing an N95 mask is non-respectful of the colleagues that depend on that for their safety because the stocks are still limited, and that would also bring a very contradicting message to the staff that does not wear any. What is also said here is there's no guideline, whether it be from Public Health or the Ministry of Health, saying that they have to isolate themselves 7 days before having to go back to regular work in cold zones. Is that is that going to lead to very negative aspects that we fear? The second part of your question, it's clear that this is a mask that is carried or worn when we had to do invasive interventions. For example, when you intubate somebody in a hospital setting, it's a kind of surgery with somebody who has COVID-19, so you have to wear the N95 mask. So if we say it in a different way from what you've read, it has to be understood that in the other circumstances, for example, in a CHSLD setting, it's the procedural mask that is worn. So it is that clarification, I believe, that the person wanted to make. What about the Trojan horse aspect? Actually, I didn't understand. There's no guideline from the Ministry of Health that people have to isolate themselves for 7 days before having to go back to regular work in cold zones, that people can circulate from one place to the next. After having come back from a hot zone, I imagine, is that what I should presume? Yes. Well, we're going to be having a look at that with Public Health. Perhaps Dr. Arruda wants to intervene? Listen, it's clear that what we've said as well is that we're having a look at that element because there were even orientations together with the people who were ill, that it takes 2 negative tests, etc. We're reevaluating all that. We have to have a balance between what I would call, if there's a problem of service, where we end up in a situation where there is a breach of service. Well, it is possible that somebody who has no symptoms. Of course, as soon as people have symptoms, it's different. They're tested and we don't let them come back. But if people come back with personal protective equipment, applying the measures very significantly, especially if has no story of previously, well, that can happen in a certain situation where, because if we leave people without care, the effect would be, if there's a breach of service of people who don't receive care, there would be higher mortalities. And that is a possibility that has to be evaluated by the establishment on a case-per-case basis. Hello, Mr. Legault. You talked abundantly about the orderlies, so we have to increase their wages. Do you still recognize that the attractiveness is not only about the wages, it's a lot, the working conditions, for example, the ratio between patients and orderlies? Well, yes, in fact, for the past year and a half, we've increased quite a bit the budgets in CHSLDs, but the positions have remained posted but unfilled. That means that because the wages were not attractive, there was a lack of staff. So the staff that was there had a much more difficult task since there weren't enough people. So it's like a vicious circle. The fact that you are missing staff because of the wages creates an additional problem because the people who are there are overburdened with work because there are unfilled positions. So the true question now is, once we filled all the positions, should we continue increasing them? Well, when we increased the budgets of CHSLDs, that was our intention, was to increase the number of people, so to modify the ratios. But where we didn't succeed is that the positions remained unfilled. So we ended up in a situation where even though we increased the budgets, we didn't spend the money because we did not attract anybody. So we can't really know whether it would have been okay if all the positions had been filled. My second question. For the time being, we still don't have any medication nor a vaccine. So we're talking about deconfinement week after week. But can we think that public health has a year-long plan, or perhaps many years, well, it's always difficult to make projections, as you know. SARS disappeared at some point, the first SARS. This one, we don't know how it's going to behave. It's clear that first, a vaccine and a treatment, we're not going to get that tomorrow morning, and we can't maintain a society, shut down like this. We have to understand that there are perverse effects of confinement, on people's mental health, on violence against women and children, on depression, mental health, and a society has to function, otherwise things can't work. So we have that balance to look at as well. So where do we, deconfine progressively? Where do we intervene? If we realize that in a sector of activity or a certain area of work, there's a case of, transmission of cases, so we have to look at the cases, the contacts, isolate them, and do the necessary interventions. And we're going to be putting the data in scenarios to be able to see what is the level of R0s that we have. So it's clear that we have, listen, I don't think that at Christmas, actually, I don't know. I'd love to tell you that on the 24th of June, we'll all be on the plains of Abraham partying together. But I think that is a scenario that is not realistic as long as we don't have a vaccine. To be able to vaccinate, and a vaccine that is safe, because we also don't want to vaccinate people with anything. As long as we don't have a treatment as such, it's clear that that virus is probably going to be coming back, or maybe disappear in the summer and come back in the fall like others. And that is why our plan is going to have to be studied constantly, and as we have new knowledge, that may change the way that we act. But it's possible that we'll still be talking about the coronavirus in 2021 or even 2022, unfortunately. I would like for you to explain to us, Mr. Legault, why it is that we can't go get 1,000 extra people in the network with all the means that we gave ourselves, whether it be public servants, whether it be graduates. We've emptied the hospitals. We had 80% of specialist doctors yesterday who were telling us that they had not yet been called by the ministry. The fact of getting the army, does that mean that we underestimated the challenge of bringing all those people into the network, or does it mean that the situation is too urgent and we just don't have the time to go get those people and we need the army? Well, listen, you saw, just as I did, and I based myself with those numbers, that there were 2,300 specialist doctors who were ready to come and work in CHSLDs. The reality is that when we ask this doctors, are you ready to come work full-time for 2 weeks as of now? There's 350 left. So, of course, maybe we overestimated the number of specialists that could come in the network of CHSLDs. But did we underestimate the challenge of acquiring those people? It's all very good to say we're going to go get graduates, but in practice, once they get to the network, it's more complicated, to integrate them. Well, if I had 2,000 specialists, having them be integrated, it would be possible. It could take a few days, and there might be a period where people have to get used to working together. But there aren't 2,000, there's 350. So we're missing hands.
Bonjour.
Hello. You talked of the numbers earlier on, Mr. Arruda. We asked twice whether there was under-evaluations of the deaths, and you said that you were confident in your numbers in the past few weeks. But we're reading this morning that your data could be considerably underestimated. Who is saying the truth? And why not having said before that there would be thousands of deaths? We said that we couldn't say anything without knowing. But thousands of deaths, there were scenarios that predicted many. And we had a scenario that we called the optimistic and one that was pessimistic, and we are somewhere between the two. And as I was saying, there's the question of delay. People think when people die, there isn't, a chip that automatically enters that data at the ministry that they've died. Our data come from cases that are available at 6 p.m. And people die most often at night, between 6 p.m. and over the night. And they're not counted in the statistics. The doctor has to go evaluate the patient, because sometimes people, you can't think that every time somebody dies automatically a doctor is on the premises. It takes a certain number of hours. They have to send that form to the Direction of Public Health that checks over the information. Because if you want to know where that patient came from, the CHSLD, if they died at the hospital, but you wanted to know where they came from, you had to go see the case, where they were beforehand, and see, where they were sent, the evolution of it. So it takes an inquiry from public health to be able to check that data and see whether it's somebody who died from COVID-19 or died of something else. So all of those processes make it that we don't have an instantaneous portrait. And it's normal, for example, that in the CHSLD you see that there's 77, but in the ministry numbers there's only 53. But if we start putting mixed data in our statistics, and secondly, what's important for me is not the statistics, is that the actions be taken. I need the statistics to plan where we're going. But once there's 2 or 3 deaths in a CHSLD, it's the intervention that has to be carried out. I prefer that my people get themselves organized to apply, and to make sure that the work is done correctly rather than, have them spend their time filling forms. We're doing that, of course, and we are trying to make the system so that we have the best data, but as little time as possible spent on it. So I think I'm very proud of the system that we set up. If we had, computer system, if we had computerized medical systems and everything was interlinked, automatically we'd be able to have that information. But we also have issues with the Commission for Access to Information. The information cannot be sent directly to the central authorities. So the numbers that we have, honestly, I believe that they are pretty close to the reality, but there is a delay, of course, in time. And with the social media, with the speed of everything that we have, the instantaneity of things, it's clear that you will hear an establishment say that they have more deaths than what we are saying, because we already have the numbers before 6 p.m. the previous evening and all. Also, perhaps the doctor didn't have the time to be able to make the notice of death. So maybe we'll be able to show you, when we have the time to do it, how things actually happen when we collect data. You asked the help of all the employees from the education network in the past few days, and they received once again a request to be able to help out in CHSLDs. What will be the procedure for the teachers who will go working in CHSLDs, for example? Will they have to stay isolated 14 days after? Because we know that there is a scarcity of teachers in schools. How can we conciliate that with the reopening of schools? Well, first, it has to be said that we're talking about teachers who teach in health sciences. So it's a small percentage of the teachers that we called out to come and help out in CHSLDs. But everybody, all job categories, received a request this week, twice from the Ministry of the Education. All jobs, all job categories come help us in CHSLDs. Those people who are going, they're teachers, secretaries. What are they going to do when they come back from CHSLDs, since we still are thinking about reopening the schools at some point? Well, for the time being, there aren't many. We have 740 teachers and students who answered the call. So we were concentrated on people who do have training in a health sector. So we'll check, but it's 740 to date that we hired. So we don't see that there would necessarily be a large impact, and we know that a lot of things are done at a distance as well. We'll have to see with education what the transition will be for those people in link with public health. On the Army, rather than wait for teachers and volunteers and doctors, why not having called the Army 10 days ago? An easy, quick, massive deployment, people who can stay more than 2 days in a CHSLD. Why? And do you regret it? Well, listen, I repeat it. And it came out on Saturday night. I talked with the president of the FMSQ, and I told her we need people full-time in our CHSLDs because we have thousands of infected people who may die. I thought that we'd be able to find specialists, 1,000, 1,500, 2,000 specialists who would be able to come full-time in CHSLDs. The result is that there's 350. So, of course, if I have the choice between people who know how to wear individual protective equipment and who have basic notions in health And a soldier who doesn't have that knowledge or those skills in health, I prefer to have people who come from the health sector. But now we have to realize that we can't. We found 1,000, so half that of what we need, but there's 1,000 left. So now we're asking the armed forces. And it's not going to be ideal, but at least it will be extra hands to help us out. About the deconfinement plan, Mr. Arruda, we've heard a lot about collective or herd immunity. We understand that the incidence of the disease on the population is pretty low. Could you tell us, to what proportion should Quebecers, do Quebecers have to catch the disease in order to have that immunity? Well, you're asking good questions, and I would love to have a chip in Quebecers to tell me I'm infected, and we get the information, but that's not how things work. We think that it's not a very large proportion of Quebecers that have been affected, particularly what I told you earlier on with the measures that we made, the stop which saved between 30 and 60,000 lives according to what the experts are estimating until the end of the summer. So it's a small proportion, and now that we think that the R0 of that virus that was estimated between 2.8 and 3 point something in China is rather around 5, that means that it will increase the proportion of individuals that have to develop that immunity. So we could go from 60 to 80% of the population that has to have developed that immunity to have a significant slowdown. So that will bring a lot higher challenges. So doing, mandatory or randomized screening in populations, because you understand that we'll have a much higher community transmission in Montreal and Laval, so a conversion rate that will be much higher there than if we were, in the Bas-Saint-Laurent area, for example, where we think that not a lot is going on. And that plus the sero-epidemiological studies are what are going to be giving us the answers, as well as the reopening, the progressive reopening, and to see how things happen in the different areas. And I want to reassure people, our main priority remains health, while still taking into account the fact that we have to reopen the economy, not for financial reasons just, but in order to avoid other dramas, things like suicides, things like divorces because of the economic situation, problems with mental health, etc. A society has to work, and it works when people can act. But we're not going to put people in peril. If we open the schools, it will be done with very different working conditions. It's not going to be like the school before. Social distancing is going to have to be respected. And if it isn't, there will be masks that will be used. So it's all that. But I look forward to being able to tell you that we are in an adequate transmission. And like other countries, since other countries are having more experience than we are before, we will be able to use that data to base ourselves. Mr. Premier, in the perspective of reopening schools, what will be the means that you are considering to know the state of the pandemic amongst the students, the teaching staff, or the general staff in schools? Are you, for example, going to ask that tests be given regularly in people who will be going to schools in order to know who has it, who doesn't, etc.? A little bit like we had decided to do in CHSLDs of saying we're going to be testing everybody. Is that something that could be applied to schools as well? Yes, it could be applied to schools. It could be applied to certain age groups within the population. There are all sorts of strategies that will also have to be taken into account. And let's not forget that the test has to be done at the right period, because if it's too early, we'd have to repeat the test. And testing children is not always that easy. But there are probably tests that could be done in certain workers, adults, because it's simpler. And we'd like to remind you again, thank goodness, complications in children are excessively rare. And by immunizing them more naturally, we actually would be helping them. But we're not going to expose people in daycares or teachers, professors, who have health problems or who are older. My other question has to do with natural immunization. Does that mean that the regions that are not as affected, for example, we're talking a lot about the Bas-Saint-Laurent region where there's almost no cases, and it's been a while that they haven't even had new cases in that region. Are the less affected regions, are they going to be at a higher risk later that there might be a return of the pandemic once they reopen, since there will be less natural immunity in those communities? For example, in Montreal, we understand that there's going to be a lot of natural immunity, at least in terms of numbers, whereas in the regions, other regions, there will be less. Well, it's going to depend on how bombarded by the virus they will be. If you allow me, the virus was it bombarded a lot of people in the Montreal region for all the reasons that we've already mentioned, the links with New York, etc. What happened over there is clear that if we look at the immunity variable or the virginality of people towards the virus, it's going to be lower. So that is a factor that will be increasing. But since we're going to reopen things progressively, we'll try to avoid that bombardment that would make it that they would develop, that will make it that they will be able to develop their capacity. But all of this has to be studied, and we have to take into account that each region has its own epidemiology and will have to have their own plan adapted to that epidemiology. And so it depends on the proportion of elderly or not. It depends on how frequent the contacts are. In big cities like Montreal, contacts are a lot more frequent than if you live, in the Bas-Saint-Laurent. Taking a walk in Montreal, you'll have more probability of having contact with other people than if you walk around your own lands in the Bas-Saint-Laurent. So all of this has to be taken into account. There are characteristics associated to the quantity of people who are immunized, but also the people's behavior and the environment in which they live. Mr. Premier, thinking about gradual deconfinement, should we think about the fact that a part of the economy or the schooling network might not be able to truly take its activities again until 2021? What are the sectors that might not be active before 2021? Well, first, I'm telling you that next week we're going to be, presenting a plan to reopen both businesses and schools. So I'm not going to scoop myself. And on top of it, it's not a question of scoop. It's a question of making sure that over the next few days that the data remains stable. But let's say that without revealing the plans, we're talking about a reopening plan that is going to be spread over until the fall, until September. So we are thinking of being able, if we're talking about businesses and schools, we think that we'll be able to reopen by September those two sectors. Now, the entire question that remains are the gatherings, cultural activities, the sports activities. Will that go until 2021? Well, it's not impossible. It's not quite linked to the subject, but if you'll allow me, because we are talking about gradual deconfinement, I would like to talk to you for 2 minutes about relaunching certain hospital sectors because I want to be able to talk about it quickly today. So I talked about it yesterday, but it has been confirmed to me that certain surgical activities are going to be started again. They're going to go to volumes of around 40% in all Quebec hospitals. So that is good news. For example, we had stopped having things like surgical surgeries or transplants. We're going to start that again, grafts. We're going to go back to medical imaging as well for all of the screening of diseases linked to cancers a lot. If we think of mammographies, that is going to start again. So that's all good news. Endoscopies are going to be starting again. And of course, what I want to tell the population is that we are going to be applying the principles of physical distancing in external clinics and everything that has to do with ambulatory care and within the hospital. Because you know that our hospitals right now work differently than they worked before. There's a hot zone, there's a cold zone. I want to reassure the population that the organization is well set up, that it is safe. Therefore, I would invite people to come for their follow-ups. The doctors are there for you. I wish to repeat it. Do not wait for chronic diseases, for example, because I'm told that there's a lot of appointments that are canceled, and if you wait, things get worse. I got a letter from the president of the surgeons, cardiovascular surgeons association, who was talking about patients who went to the emergency ward too late, unfortunately. So I would invite the population to please come see their doctors when it's urgent, to not wait, to call the ambulance or come to the hospital. So that's all good news. We are starting with our activities in hospitals as well. But just one thing, I'm sorry, but you'll agree with me, Daniel. We are starting those activities again, but the semi-urgent ones. We never stop the urgent activities. We are starting again with the non-urgent ones. But the ones that can be postponed should continue being postponed. And the specialists, the doctors who are available, should come in CHSLDs. Well, Mr. Premier, you're absolutely right. We have to clarify that, yes, because it's not always easy to explain. It's not always, all that easy to understand, is that there is a balance, which is not simple to reach, but I've always said so. When we asked for specialist doctors, the inactive specialists, we're not opening elective surgery right now, not at all. We can't, because, amongst other reasons, the non-availability or insufficient availability of sedation medication. So all of those doctors, all those specialists are available. But of course, when we start taking up certain activities again, that does not affect the elective activities. We're going with the semi-urgent ones. But a semi-urgent that has been waiting for a month, well, it becomes urgent. So it's those activities that we're taking up again, and everything having to do with screening as well, which is very important. And if you allow me, I want to answer. I saw in the nonverbal of one of your colleagues that my answer was not satisfactory, talking about the Bas-Saint-Laurent area. What I wish to say is that in the strategies that could be adopted in those areas where the risk could be higher because there was no transmission, is to maintain the people at risk in confinement longer and to let the young people expose themselves. That is part of a strategy. Perhaps my answer was not was not responding to your concern. So I was allowing Mr. Premier to having been in competition with you because we've talked a lot today in the past few seconds. So thank you for allowing me to say that. Mr. Premier, you talked a lot about, Quebec Pride since the beginning of your mandate. And even recently, we were fighting the pandemic at the beginning. And now when we can see that the numbers are pretty serious in CHSLDs, and we're now calling out to 1,000 soldiers who are not necessarily trained, is the Quebec Pride, isn't it being hit a little bit? Well, listen. The problem that exists today in our CHSLDs is not a new problem. This is a problem that has been there for many years. This is a problem that we tried to fix by increasing the budgets of CHSLDs, but we did not succeed because a lot of positions remain unfilled. So I've said it. We arrived in this crisis badly equipped in our CHSLDs, in our residences for the elderly. So that part of it, there's a lot of work to be done. I think that once the crisis is over, we're going to have to make sure that we treat our elderly much better. Yes, it is in fact embarrassing what we have in front of us. We've tried to fix it, but we did not succeed. And we will succeed in the next months in fixing this, because I want us to be proud of the Quebec society as a whole, including the way that we treat our elderly in CHSLDs. I just wanted to support what the Premier is saying, but also I want to support all Quebecers who, up until now, have respected our guidelines of social distancing, etc. That has allowed us, to reduce the invisible impact. And by that I mean all the lives that we saved in the community. And also, I'm very proud of Quebec businesses and, the daycare and schools that will be reopening, in respecting the guidelines that we'll be setting up, because what we'll be doing in the future is going to be changed forever, working from home, etc. So we have to remain proud of what we've done. We have to think of what happened in our CHSLDs. And as a community, beyond the institutions, we have to think of how we act or how we interact with our elderly in Quebec. It's also a question of society. It's an issue of society. So let's be proud of what we are. Let's remain united, not divided, if we want to be able to see those better days coming up ahead. That's an end to the French questions.
Bonjour, bon après-midi. La Dr. Joanne
Dr. Joanne Diou is a worldwide renowned expert. Will she be integrated to your crisis unit? I spoke with Dr. Yu this week, and yes, I have a lot of admiration for Dr. Yu. I've followed her career, that's what I told her, and we had a very good exchange, and in fact, Dr. Arruda spoke with her as well. She is in link with Ms. Rose Bush, the Deputy Minister who takes care of everything with living environments. So Dr. Liu is going to certainly be involved in the file for the prevention of infections. We have teams that we have to set up, more important ones, to be able to go to all CHSLDs for infection prevention. We already have teams in the establishments, but taking into account the present situation, we have to do more. We have to put more people that will be taking care of infection prevention, and Dr. Liu is going to be working with us on that. And she's also going to be working with the non-traditional sites file, because she knows that very well for having worked in all sorts of epidemics. So the non-traditional sites that are developed in Quebec to give us more space in order to be able to separate people who have COVID-19 and have them away from people who don't have them in CHSLD. So we're developing these more and more. And there's the Hôtel Dieu coming to Montreal, about 100 beds. And Dr. Liu is going to be involved in that file as well. Amongst the 1,000 soldiers that you're calling as reinforcement, there's 550 who have no medical training whatsoever, since there are 450 that have it. For the time being, we only have 65 soldiers that have training. There may be another 65 that will be arriving with training in health, but all the others, so the 1,000 that we're asking, do not have training in health. Okay, well, that's my question. Rather than calling out to soldiers with no medical training, why not going to get doctors who came from other countries, who have passed all their exams and that are at the stage of doing the residency or launching the call to all Quebecers? I want to be very clear, because I've seen that a couple of times as a proposal. We are not refusing any foreign doctor who wants to come as a nurse or as an orderly. As a doctor, that's not where we're missing staff. What we're missing are nurses and orderlies. So if there are doctors, foreign doctors, that are ready to come and work and to give basic care in our CHSLDs, we are wide open to welcome them. But as doctors, that's not where the scarcity is right now. And that is the problem that we had at the beginning, is that specialist doctors wanted to replace family doctors, but we weren't missing any family doctors in CHSLDs. That wasn't the problem. What we're missing are nurses and orderlies. We tried to bring more specialists that would come and act as nurses. We found 350. But now we have not been able to find any, and that is why we went to get those soldiers. Thank you. English questions now.
First question, Cathy Sonnet, CBC News.
Good afternoon. Experts say that the province will need to do far more testing when we open back businesses and schools. Now that you are planning to propose a plan next week, how the province is prepared for this?
The plan is going to be announced next week. Does it mean that next week everything is going to be open? First of all, it's a progressive approach. So we are working, actually, we are buying some material to make some seroepidemiologic studies on people. And we want to also do testing and test. And that will be part of the strategy when we're going to open different sectors to test the population, even not the ones that are on CHSLDs and everything. We're going to keep the capacity to diagnose the disease if there is outbreaks or specific situations, but we will augment the capacity of testing in labs too.
Second question. I'm sorry, Mrs. McCann, but we're still hearing stories about protective equipment. I mean, private CHSLDs, unions representing public staff. How can it be possible that frontline staff are saying one thing and you're saying another thing, saying that they don't have the protective equipment they need?
Well, we have the protective equipment. I can only say that. I think it's a problem of distribution at certain points. But, I receive calls and emails of situations like that once every day, and we respond very, very quickly. So what I say again today, we want to know where and now how we respond, not 24 hours. The same day they're getting the material. So, of course, ideally, we would like the distribution to be perfect. We have 2,600 places where we have elderlies. Some of them are in the private sector. And, this is a new situation. In general, I would say to you that the distribution is going well, but I know there are exceptions. So tell us, call us, email us. We will respond in the next hour. We're organized that way. They should have all the equipment, and we have the equipment to give them.
Next question, Samuel Pouliot, CTV.
Hi, talking about protective equipment, we have a case at Lakeshore General Hospitals where doctors and nurses are receiving expired N95 masks. Some of the masks appear to have expired as much as 11 years ago. Why are the frontline workers receiving expired masks, and who's responsible for the checking of these equipment?
We're going to look into that. I mean, we have N95 masks. We have enough to give what's needed. So after the press conference, there's going to be a call, and we want to know what's going on, and we'll send up-to-date N95. There's no reason for this to happen. We're going to check everything on that.
Okay, question. We know there have been some cases at the Sacré-Cœur Hospital where COVID patients have infected cancer patients or other immune-compromised patients. Staff even anticipated that happening. Is there any way to stop the spread of the virus within institutions?
That is very preoccupying. And I want to clarify right now that there should be no confusion here, that Sacré-Cœur Hospital is a designated hospital for COVID-19 patients. They have over 100 patients of COVID-19. They have the capacity to give them the care they need. That zone is completely separated from the rest of the hospital. And I asked for a description of the situation because I became aware of it recently. So I want to tell you that our hospitals now are organized like this. There's a hospital inside of the hospital. There's a hospital for COVID-19 patients, and it's hermetically closed. There's no contact with the rest of the hospital. There are other services. For instance, at Sacré-Cœur, there's the oncology service, the dialysis service. In those services, they have to organize the care separated for COVID-19 patients. There are some patients, cancer patients who have COVID-19. They have to be treated at different hours in the different section of the hospital, and the ones who don't have it in a separate section. The same in dialysis. So I am aware that the patient in oncology died of COVID-19, but I want to make sure that people understand that the COVID-19 patients, as a designated hospital, they're in a very, very closed area of the hospital, no contact with the rest.
Thank you. The next question is from Phil Autier, Montreal Gazette, for Mr. Legault. We know Quebec's COVID-19 outbreak is concentrated in the long-term care centers, mainly in Montreal, and our hospitals are not overwhelmed. So why does the whole province have to be in lockdown? How realistic is it to open one region over another?
But that's what we'll announce next week. But of course, we have to take into consideration that the cases are very concentrated in Montreal and in Laval. So we have to take that into consideration to decide where we open schools first. Of course, it means also we have to be careful still for traveling between regions.
Phil's second question is for Mr. Arruda. On Tuesday, Ontario's Chief Medical Officer of Health said the number of confirmed cases will have to drop to 200 new cases a day or less before the province can start reopening the economy. Do you concur with your colleague? What will be the magic number for Quebec?
The magic number is not everywhere the same place. It depends on the local epidemiology. So if it's 200, it's because of the curve they are using, and depends of what they do calculate on the curve. We have, as I was telling, we have probable cases that are not the ones that are counted in Ontario. So what I can say, it's not going to be a number. It's going to be a deceleration of transmission and the calculation of the R0, which is do each case give more than one case or less than one case in a mean of transmission.
And now a question from Raquel Fletcher, Global News, for Mr. Legault. First, Vigie Santé, a private long-term care residence in Dollard-des-Ormeaux, wrote to families of its residents yesterday saying it has seen no sign of help yet. What do you say to them?
There's been help. The last report I got was just before the press conference, and the CIUS West de Lille is really sending staff to help this private RPA, and it's going to be sufficient to give the care to all the people. So the situation is being taken care of.
Thank you. And again for Mr. Legault, when we look at the different graphs showing death per million, Quebec is very high. How does that make you feel, Premier?
But first, like Dr. Arruda explained before, we first need to compare comparables. Right now in Quebec, we declare all deaths, including in long-term care, which is not the case in all countries. And if we compare with countries having large cities like Montreal, countries like France, Spain, Italy, United Kingdom, they all have more death per million of population than Quebec.